Hello everyone, my name is Gary Clemons. I am a student at the University of New England, and today we're going to be talking about, I'm going to be going through the presentation of sickle cell disease. We'll start right at the gene level and then follow the story all the way down to what we see in the clinic. I'll connect how a single mutation changes the red blood cell and how that leads to organ damage, and then follow up to what we can do for patients for both now and in the future. Here's the plan for our session. I'll begin with a brief overview, then we'll move into the genetics and the cellular biology of sickle cell disease. From there, we'll look at how the disease is diagnosed and what the clinical features look like. I'll highlight the prevention strategies and the critical role allied health professionals play. After that, we'll cover current treatments and the exciting new gene therapies that are changing the landscape. Finally, we'll wrap up with the outlook and the references. Sickle cell disease is a inherited blood disorder that changes the way that hemoglobin functions. When this abnormal hemoglobin releases oxygen, the red blood cells deform into sickled shapes. Those sickled cells don't move through small vesicles very well, and that leads to anemia, painful vaso-occlusive crisis, and gradual organ damage over time. This disease is far from rare. It affects millions of people worldwide, especially in populations across Africa, the Middle East, India, and the Mediterranean. At a cellular level, the real problem is polymerization of hemoglobin S when oxygen is low. That forces the red blood cells into a rigid sickle shape. These cells are fragile. They break apart much earlier than normal red blood cells, which causes the chronic anemia. At the same time, they clog tiny blood vessels, which blocks the oxygen delivery and triggers inflammation. Together, that combination drives pain, tissue injury, and long-term complications we see today in patients. All of this comes back to a single genetic change. It's a missense mutation in the HBB gene, where glutamic acid is replaced by valine in the beta-globin chain. The inheritance pattern is autosomal recessive, which means that a person needs two abnormal copies to develop the disease. One abnormal copy makes a carrier, but typically carriers don't get sick themselves. And importantly, this is not sex-linked. Both men and women are equally affected. In the United States, every newborn is screened for sickle cell disease, and that allows us to catch the cases early. Confirmation testing is done with hemoglobin electrophoresis or a high-performance liquid chromatography, and sometimes DNA testing if the case is unclear. For families who are at risk, prenatal testing is available, and for the adults who weren't screened at birth, we rely on clinical suspicion and follow-up testing if the symptoms or history suggests of sickle cell disease. Clinically, sickle cell disease shows up in several ways. The most recognizable are the painful occlusive crisis, the chronic anemia, and acute chest syndrome. Young children are especially vulnerable to infections because their spleens stop working properly. Stroke is also a real concern, not only in children, but in the adults as well. And over time, the repeated episodes of sickling and tissue damage lead to complications across multiple organs. The organ impact is widespread. The spleen gets damaged early, which raises the risk of serious infections. The brain can be affected by both ischemic and hemorrhagic strokes. The kidneys lose their ability to concentrate urine and may eventually fail. The lungs can develop pulmonary hypertension, which limits the activity and shortens lifespan. And even the bones and joints suffer. Repeated poor blood flow, which leads to avascular necrosis and chronic pain. Not every patient experiences the disease the same, though. Triggers like dehydration, infection, or altitude can make sickling much worse. On the other hand, higher levels of fetal hemoglobin provide protection, which is exactly why hydrourea works. It raises the fetal hemoglobin and reduces the crisis. Genetic modifiers like variants in the BCL11 alpha also help by keeping fetal hemoglobin levels high. So, severity of the disease reflects both the genetic background and the patient's environment. Prevention is critical. Carrier screening and genetic counseling help families make informed decisions, and pre implantation genetic testing can prevent transmission. For children, vaccines and penicillin prophylaxis are life saving. The dietitians play a huge role in supporting growth and managing anemia. Physical therapists help with the mobility and pain management. In truth, sickle cell care is a team effort. And when prevention and chronic care are done well, the patients need fewer hospital visits and live fuller lives. When it comes to treatment, hydroxyurea is our first line therapy. As discussed, it lowers the frequency of the crisis by boosting fetal hemoglobin, and for children at high risk of stroke, chronic transfusions are used to prevent the devastating complication. Supportive care, such as pain control, oxygen, and infection prevention, is equally important. And in selected patients with a suitable donor, stem cells transplantation is curative, although sometimes it's not widely accessible. We are now entering into a new era of treatment. Two gene therapies are FDA approved at this time: Casgevy and Lyfgenia. Casgevy uses the CRISPR base editing to turn fetal hemoglobin back on, while Lyfgenia introduces a modified beta globin gene, and these highly specialized treatments delivered at select centers, and patients need close, long-term follow-up. But the results are so far are very promising, durable, disease modifying, and in some cases, life changing. The outlook today is much more helpful than in the past. With newborn screening, comprehensive care, and modern treatment, survival and quality of life have both improved. Gene therapy brings us closer than ever to the real cure. But we still face big challenges: access to care, affordability, and the question of how to bring these breakthroughs to parts of the world when sickle cell disease is most common. To wrap it all up, a single DNA base change alters the protein and then rewires the physiology of an entire system. Understanding what the molecular biology helps us explain the symptoms, predict complications, and design therapies. Right now, we already have the powerful tools to modify disease. And for the first time, we have a curative treatments on the table. The future is brighter than it has ever been for sickle cell patients. The evidence for what I've shared comes from a strong base of research, randomized trial from hydrourea and transfusion therapy, large-scale studies of comprehensive care, and now the groundbreaking trials of gene therapy. These studies give us the confidence to treat today and the direction for where research should go next. Again, my name is Gary Clemons. I'm a student at University of New England, and I'm taking a cellular biology class. Thank you for your time.